I'll take care of it. Okay. Ladies and gentlemen, Commission is called to order the meeting. Just have a couple preliminary remarks to make before we begin today's business. Ladies and gentlemen, this is my first meeting as chairman of the Maryland Healthcare Commission. And I just want to say for the record that I am profoundly humbled at the appointment by the governor. I'm especially honored that the governor of Maryland, Governor Hogan, has expressed his confidence in me to undertake this task. This commission has a very big mission. If you look at the statutory responsibilities of the commission, we're responsible for promoting policies to expand health insurance coverage and care, access to quality care, and to control costs. We exercise a variety of powers to do that. We're executives in the sense that we enforce the laws, the rules, and the regulations of Maryland to enforce those regulatory agenda we have. We're also legislators. We actually make the rules that govern this sector of the economy, and we're judges. We make decisions weighing oftentimes very, very difficult issues of competing goods and the very, very complex issues dealing with certificate of need, for example. But in any event, I just wanted to say, for the record, that I deeply appreciate many of the wonderful comments that have been sent my way. I have profound respect for the members of this commission. I also have profound respect for the staff of this commission. The staff of this commission has done an outstanding job. They are a model of civil service. Their hard work, their professionalism, their dedication. We talk about it privately among ourselves. I mean the commissioners, but I'm restating for the record the public truth that the staff of this commission does an outstanding job. And I'm honored to be a part of that process. So without further ado, let's get to work. Item 1 is the minutes, the approval of minutes in your packets. Ladies and gentlemen, there are copies of the minutes from the April 20th, 2017 public meeting. You've all had an opportunity to read these minutes. If there are no changes or there are no corrections to those minutes, I would like to entertain a motion for approval. Do I have a motion? Commissioner Flagg. Second. Commissioner Sargent. Very good, thank you. All those in favor say aye. Aye. The ayes have it. We're going to skip to agenda item number 3. And the reason we're doing that is in the interest of time. But agenda item number 3 deals with Stella Maris. Stella Maris Incorporated applied for a certificate of need to construct a building addition and renovate its existing facilities. Kevin McDonald, who is the chief of certificate of need, will present the staff recommendation. Mr. McDonald, it's over to you. You have the floor.
Thank you, Commissioner Moffitt. Chairman Moffitt. Good. Stella Maris, the applicant, is a 412-bed nursing home, which has specialized programs for subacute care as well as dementia care. Also operates on the same campus, independent living apartments and a hospice program, including an inpatient hospice program. They're an affiliate of Mercy Health Services. It's an older facility. It opened in 1953 and has added incrementally over time in subsequent decades. Currently, significant portions of the facility do not meet 2010 American with Disability Act standards. They are effectively grandfathered. And while the facility many of the rooms meet COMAR requirements for room size, they don't meet the recommended size. Despite that, the bed occupancy is about 92% for the most recent 24 months, and it's about 2 or 3 points higher than the jurisdictional occupancy rate. And Stella Maris has also exceeded the Maryland average on a majority of select quality measures that MHCC staff considers among the most important. This proposed project would add 75,000 square feet of new construction and renovate a little over 5,000 square feet. It would replace 60 outdated beds in a wing built in 1966 with two 30-bed private rooms and a shelled floor that would accommodate future replacement of more of the outdated beds. Private rooms would increase from 114 to 160. The primary objective of the project is to initiate a master plan to correct deficiencies in the facility over time. So this would be the first bite at that. Key considerations, looking at our standards and criteria, as mentioned, quality exceeded the Maryland average on a majority of select measures. Need for the project is predicated not on the need for more beds or the addition of more beds, but to modernize the facility. Their occupancy is robust. The jurisdictional occupancy in Baltimore County is healthy at about 89%, averaging over the last 3 years, slightly above the state average. Impact on other providers is likely to be minimal, given that this is really just renovating existing beds, not adding to the bed supply. The applicant appears to have done a very thorough analysis of 4 options and selected the one that it felt best met its goals within the budget that it considered feasible. In terms of viability and financial feasibility, Mercy Health Services has a positive track record in managing debt financing. Stella Maris has been operating with a positive bottom line and makes projections that positive bottom line, while being less than it currently is, would continue into the future after the project. In summary, staff recommends approval of the project with our 2 standard nursing home conditions. One being that Stella Maris would provide the commission with a memorandum of understanding with Maryland Medicaid, agreeing to maintain at least the minimum proportion of Medicaid days required in our state health plan standard, and that they shall meet and maintain that minimum proportion of Medicaid days as required in that memorandum of understanding. With us today from the applicant is Steve Stinnett, who's the Chief Financial Officer, Judith Weiland, Senior Vice President for Strategic and Capital Planning for Mercy Health Services, Rick Abbott, the architect on the project, Andy Solberg, their CON consultant, and James Buck, their attorney.
Welcome to the commission. Thank you very much. Any questions for Mr. McDonald? Any observations? Commissioner Phillips.
Thank you, Mr. Chair, and thank you, McDonald. I apologize for my voice today, but I'll try to briefly ask a question. And the question is, this is a CON application that does not involve a new service. It doesn't involve an expansion of existing services. It's not a new location. It's self-financed in terms of projections. So I guess the fundamental public policy question is, how did this application rise to the need of having a CON? In other words, how are we serving the public's interest by asking this provider to go through this CON process?
The literal answer to your question is that it's required under the way the statute is currently written, and our CON regs reflect that statute. From a more philosophical or policy, to give you a more philosophical or policy-oriented response, the reason nursing homes in general obviously are submitted to CON is that there are public dollars involved, Medicare and Medicaid, and that we need to also look at the impact on the health system in terms of supply, oversupply, and effect on other providers. In this case, that does not come into play. Having said that, though, you know, this particular set of circumstances does beg that question. It would probably be useful if we could develop some kind of abbreviated process or expedited process. The Commission may still want to look at applications like this to ensure that existing quality ratings are maintained, that there is financial viability, significant dollars are being borrowed on this project, and that we're doing due diligence that the project does indeed not add capacity. So, you know, if we could come up with an abbreviated process, I think that certainly would be a good idea. Other than that, it would really take a statutory change.
Right, thank you. So what is the threshold, the capital investment threshold that's been bumped up against with this, I guess, $30 million?
For nursing homes, I think it's about $6 million presently.
6. So the statute for every level of provider has a dollar amount in the statute that triggers a CON.
It's different for hospitals than
right,
it is for
but it's a fixed dollar amount.
Yes, and there are categorical reasons that something would be submitted to a CON as well. Addition of beds, new service.
Right. I get all that, but okay. Thank you, Kevin.
But this fits it on the dollars.
Thank you.
Any other questions? Do I have a motion to approve the certificate of need for Stella Maris? Commissioner Stolenwork. Okay. All those in favor, say aye. Aye. Any opposed? Thank you. I'm still getting used to this job, so bear with me. I forgot to introduce our new commissioner, who was just appointed by Governor Hogan, Mr. Marcus Wang. Commissioner Wang is an attorney by training. He is currently president and general manager of Zytogen Global Genetics Institute, and he assists patients and individuals pursuing in vitro fertilization. Mr. Wang was raised in Baltimore County. He attended Gilman School, and he graduated from Harvard University before completing his legal training at the University of Maryland. Commissioner Wang, welcome to the Commission. You're going to bring a very vital perspective to the Commission. A person who's involved in biomedical research. I expect that you will have an entertaining time with us. But ladies and gentlemen, join me in welcoming our new Commissioner. Okay. Thank you. Okay, agenda item 4 is the state health plan for facilities and services, the freestanding medical facilities, and we've had several meetings on this in the past, and now we are going to discuss final regulations. Eileen Fleck, who is the Chief of Acute Care Policy and Planning for the Commission, will summarize the comments that we received on the proposed regulation, COMAR 102419, the State Health Plan chapter for freestanding medical facilities. That was adopted by the Commission as proposed permanent regulations in February 16, 2017. Ms. Fleck will present the staff recommendations for the final permanent regulations. Oh, sorry. Would you hold on for 1 second? I'm still getting the hang of this. The attorney for Stella Maris would like to say something nice. Please do.
On behalf of Stella Maris and Mercy Health Services, I wanted to take the opportunity to thank the Commission and the Commission staff for their review of the application, and particularly the Commission staff for all the pre-planning work that went into it. Very much appreciated. I'm looking forward to moving our project forward.
Thank you very much, and we deeply appreciate that. Thank you so much. Eileen, I'm sorry.
Fine.
You're on.
Good afternoon, Mr. Chair and Commissioners. Staff received formal comments on the state plan chapter for freestanding medical facilities from Anne Arundel Medical Center, the University of Maryland Medical System, and David B. Paris. As noted in the staff memo, the University of Maryland Medical System expressed support for the proposed regulations, and Anne Arundel Medical Center requested clarification on one issue, but it did not raise any proposed changes. David Paris, however, raised several issues. I'll go over most of those now. They are covered in detail in the memo. First, he stated that the public interest is not served by the regulations because hospitals seeking to maintain inpatient services are discriminated against. Staff recommends no change in response to this comment because the regulations neither encourage nor discourage a hospital to downsize, and the regulations are consistent with implementing state law that allows for conversion of a general hospital to a freestanding medical facility through the exemption process. Mr. Paris also commented that the state should encourage the creation and integration of emergency and urgent care centers and conduct objective studies of major hospital changes. Staff again recommends no change in response to these comments because hospitals already have the ability to develop urgent care centers in conjunction with emergency departments, and a requirement for objective studies of major hospital changes would be unduly burdensome. Mr. Paris also commented that the regulations should be modified to provide incentives for hospitals to address improving access to care, reducing expenses, and increasing competition. Staff recommends no change in response to this comment because we've concluded that the regulations sufficiently promote access to care at a lower cost by creating a process that allows a hospital seeking to close to maintain emergency services and other services, potentially through a streamlined process, which is the exemption process. In addition, there are requirements for CON applicants related to access and cost. Mr. Paris also commented that patient advocates were poorly representative on the freestanding medical facility advisory group, and there was insufficient effort from MHCC staff to solicit comments from the general public. Staff notes that the work group did include one patient representative, and that's typical for our work groups that there's just one representative. Staff also notes that the public comments were solicited in the Maryland Register and on the website, as well as through Twitter, and Twitter is something new that we did. Lastly, Mr. Paris commented that MHCC delayed implementation of the regulations, which is inconsistent with the legislative direction for licensing to begin July 1st, 2015. I would note that staff has communicated with the legislative staff throughout this process of developing the regulations, and due to legislation anticipated in the 2016 session, we felt that it made sense to delay promulgating these regulations and asking for the commission to go through this process. And in fact, there were legislative changes that did occur in that session. So that concludes my presentation. I'd be happy to answer any questions at this time, and I also would like to ask that the commission adopt final permanent regulations, COMAR 102419, the state health plan for facilities and services, freestanding medical facilities.
Thank you very much, Ms. Fleck. Fellow commissioners, are there any questions or for Eileen? Anybody at all?
I had one just.
Commissioner Sargent. Yeah.
It's about the Anne Arundel question. We said that it was the, I guess what it is, I think I understand the state requirement why an independent hospital. Can you explain a little bit about the federal requirement that makes it so an independent hospital wouldn't be able to convert to an FMF?
Well, the federal requirement is for someone that's certified by Medicare and Medicaid to have a parent hospital, and for the FMF to be administratively part of a hospital. And there are some other specific things in terms of like the distance it can be from the provider and other indications that it is in fact closely tied to a parent hospital. So those are federal regulations. That's not something which is in state law.
Right. Okay. Thank you.
Okay. Any other further questions? Any further questions? I need a motion to adopt the COMAR 102419 regulations as final regulations. Do I have a motion? Commissioner Thomas, thank you. Any seconds? Second. Okay. Any further discussion? Fine. All those in favor say aye. Any opposed? No. Okay. Thank you very much. Thank you. Thank you, Ms. White. Yes. Director?
I wanted to note that with the adoption of these regulations, this really completes about 2 years of work. I want to recognize Eileen for the work that she's done on the regulations and her patience in refining them consistent with the Commission's thoughts and input from the community. I believe that the work now begins on for the Commission, that we expect an application, perhaps 2 over the next 6 months, to convert a acute care hospital into a freestanding medical facility. There's a considerable due process that takes place, and we'll keep the commissioners informed as we move forward. But thank you very much for all the work.
Thank you.
The next item has to do with information exchange, privacy and security. Where the Commission is being asked to consider final regulations. Angela Ebott, who is the Chief of Health Information Exchange, will present for consideration as final regulations COMAR 102518. These rules were adopted by the Commission as proposed permanent regulations on January 26th of this year. These regulations address the privacy and security of protected health information that is obtained or released through a health information exchange operating in Maryland. Ms. Ebott,
thank you.
The floor is yours.
Thank you, Chair. Thank you, Commissioners. I'll be very brief as this is the final amendments, and I'll go through them quickly. In general, the amendments apply to HIEs that choose to provide consumer access, and it ensures that they offer it in such a way that ensures the privacy and security of the patient's health information. It also addresses electronic access in terms of view, download, transfer, control, and submit, which is in alignment with meaningful use requirements. And it does apply requirements to HIEs to provide consumers with electronic access to their disclosure report. A little bit of background about our regulations. These regulations went into effect initially on March 17th of 2014. They were amended in June 20th in 2016 to address some secondary data use for research purposes. The regulations require the MHCC to register HIEs that operate in Maryland. Currently we have 7 in addition to our statewide HIE, or CRISP, and those are listed here. In terms of the development of our regulations, we work with a staff advisory board, our HIE policy board, made up of a diverse set of consumers. We released draft amendments to the regulation in December and used those 13 comments and several letters of support to make changes to the draft before we proposed at the January 26th meeting. So in terms of the amendments, which are you've seen before, in terms of access, the HIE must appropriately verify the identity of a healthcare consumer before they provide access to either view, download, transmit, submit, control. They can also are required to allow consumers to authorize someone else to have access to their information. This could be a caregiver, a family member. And they may charge a cost-based, reasonable published fee for that electronic access that's applicable, compliant with applicable laws. In terms of view access, patients must provide access in the form or view in a form that is equivalent to what is provided to a healthcare provider. Certain attributes must be provided in terms of the date of the service, the type of service that was provided, and they must provide information to a healthcare consumer about their health information, how to access additional resources or educational content, how to interpret their health information. And it must be presented in such a way that's easy to navigate and its principles. In terms of download, transfer, and control, HIE that offers the ability to control their health information must implement current technology standards around that control, as well as if a HIE provides the ability to download and transmit that information, that those protocols that are currently adopted within in the industry must be applied to. The ability to submit, an HIE that offers healthcare consumers the ability to submit must identify that source of the information when it's then being made available to a healthcare provider, so that provider knows that the source might be a healthcare consumer or their caregiver. And they must also not override that patient consumer's information with other information that might be provided by a provider. An HIE must also provide consumer education around who they can authorize to provide that information, such as a caregiver, what information they need to provide as part of identity proofing, as well as what level of control they might have with that HIE, and information about securing their information if they do download and transmit it to another source. The amendments also require within 6 months of the HIE establish a process that allow consumers to have an electronic copy of the disclosure report. So this is those individuals or healthcare providers that have accessed their information through the HIE, discloses who they are and what information they provided. The amendments also state a few exemption provisions where an HIE may request a 1-year exemption from certain requirements in the regulation. These requirements cannot be anything that is required under applicable or federal law or state law. They must explain the reasoning for or justification around these exemptions, and it would be under the determination of the commission to approve those exemptions. So in terms of the comments we received 2 letters of formal comment, one from a longtime member of a HIE policy board and a consumer advocate who provided support around these amendments, saying that they enhanced and provided better clarification and are appropriately balanced. We also received comment from the Maryland Office of the Attorney General's Health Education and Advocacy Unit, or HEAU. These recommended changes were to align with current provisions in laws around consumer rights, as well as additional clarification. So in your packet, you should see responses to each of the comments that were received under those 2 letters. In addition to our justification where no changes are recommended, there are 3 areas in which we would recommend non-substantive changes, which I'll outline very quickly. One is around subsection 12A1, where the requirements are around clarifying the acceptance of patient health information before that information, or identity proofing the patient before they accept information on behalf of the patient. This is usually when the patient is submitting information. So we recommend that clarification, as well as in section 12B1, where we're talking about the cost, a reasonable cost to consumer for providing that electronic access. And we recommending adding the word cost-based to align with current laws around providing access and charging consumers, as well as some alignment of the definition of download in section 0.02B to align with the language also where references download under section 0.12. So staff recommends the commission adopt the proposed amendments as final with those 3 non-substantive changes. If approved, it'll go into effect June 19th.
Ms. Yvonne, fellow commissioners, are there any questions for Ms. Yvonne? Yes, Commissioner Sullenberg.
Thank you. Probably doesn't surprise you that I have questions. First of all, I'll start by saying I love this. I'll just make that absolutely crystal clear. It is really gratifying to see progress when I realized earlier conversations we had a while ago it was just about understanding if consumer access to when information had been disclosed to somebody, but no direct access for consumers themselves. So this is a huge step forward, so thank you. I have a couple of questions. So with the various numbers of HIEs, I wouldn't have a clue which HIE to go to get my information. How would a consumer know which HIE to go to access their information?
So HIEs are required to require their participants. So providers that are providing information to an HIE must inform about their participation with that HIE, so they have the opportunity to opt out. So at that time, they can be provided with information about gathering or accessing their health records. The regulations don't necessarily require an HIE to provide that access, but if they do, they have to meet these protections.
So wait, I want to back up and understand. So if an HIE chooses not to allow consumers access, am I understanding that, or
yes? So
HIEs can still opt out and not let consumers have access to their records?
They can choose not to offer that access, yes. But they do have to they're required to provide a disclosure report, an electronic disclosure report, which gives the patient an understanding of who has access to information.
Oh, okay. So now I have to revise my glowing excitement about this. So this is a start.
Yes.
So if they choose to give access, they have to follow all these requirements,
yes,
which could actually stop some of them from giving access, because if I have to either do all or nothing, I may choose nothing if I don't like all of these requirements.
Well, we discussed that in the policy board at length in terms of, are these requirements sort of hindering HIEs to provide the access because they're overburdensome? What we've heard from our group was that it wouldn't.
When you say the group, is it the HIEs who are saying that this wouldn't hinder access?
The HIE policy board, which include representation from them.
So yeah, do you have a sense that all of the HIEs are going to choose to comply?
We don't necessarily have that sense, no.
Okay. And then when you talk about electronic access to something and trying to figure out the cost of one individual accessing their records, I mean, I assume it's like a tiny marginal cost, that it would probably almost be administratively burdensome to charge the 0.03 cents,
Yeah.
or whatever it might be. I mean, is there some sense of what is anticipated a cost-based charge would be for a consumer to access their medical records?
Not necessarily in the electronic world. HIPAA, and there are certain guidance around paper copies, as you know, in terms of how much to charge for 5 pages of paper records, but not necessarily that sense in terms of the electronic cost. As part of HIE registration, we gather extensive amount of information from our HIEs to understand what services they're providing, not just to providers, but now that we have consumers involved, what they're providing to consumers. And that's certainly something that we can assess in the registration process to understand what the reasonable cost base looks like for our HIE.
It would be really helpful, I think, to find out who's giving access, how are they letting the consumers know. I saw the requirement that they need to let them know, but we also know that there are organizations who will post something on their own website, and that's what they use to let people know. But if you don't know to go to the website, you don't know that access is available.
Right.
So do they provide access to consumers? How are they letting the consumers who are part of their HIE know that they can access their medical records through this? What are they charging for that access, and what is the cost basis underlying that charge? Because again, when you're dealing with paper records, it involves staff time, it involves paper supplies, ink, all of that. Whereas electronically, it is so minuscule, it's hard to imagine what a cost-based charge would actually be. Thank you.
Yes. Commissioner Thomas.
So I like to think that everybody's as sophisticated as me, but every now and then I still go the old-fashioned way with paper. So I have a question for you. In your opinion, do you think there are subgroups of our community that might find this more difficult? And if so, who might they be?
In terms of accessing their electronic health records,
Yeah.
I suspect, so I can give you a own personal example. I actually access my father's records from Blue Button. So it's an initiative under Medicare, and you can access information for Medicare. Not very tech savvy, but I sort of assisted him, and I was almost sort of curious about what was being provided. I suspect that type of population might not be as tech savvy to go to the HIE and request their information, and go to HIE third party to request their information. However, I feel like there are some organizations as well as family members that provide that assistance. And if patients are interested in more of the paper records, they certainly can get that through their provider that they're having that encounter with. After the encounter, going to the front desk and getting the paper records.
So let's stay there with your example for a moment.
Sure.
So lucky your father has you to call on.
He's learning a lot more, though, by the way.
So you did a little hand-holding with your dad. He gave you access to all the information, the codes, the passwords to get into the account.
Yeah, actually set up his account for him.
You set up his account for him. Okay. Now, are there restrictions if you were to read the fine print that would have made it inappropriate for you, the non-patient, to set up that account?
So we do require, if they're going to give access to a patient, that they allow that patient to designate somebody to give that access.
Okay.
So that would be allowed.
And it's not based on blood relation.
No, it's not. It's who the consumer designates as who would have authorization doesn't necessarily have to be sort of their legal guardian.
Okay.
Or the like. And we had a extensive conversation about that as well as a policy board.
And it's just the last question. A number of health departments in the state are using community health workers as a way of navigating and connecting. Are community health workers in their training prepared to play a role like that?
I'm not that familiar with community health workers training. I do work with some community health workers under our telehealth pilot, because we work with community health workers. It's certainly something that I would feel that they would need training on or have the information about. We can certainly reach out to those folks about that training and who they're offering access, having that information available to community health workers.
Thank you.
So my executive director has motioned me to the front of the room. So
you better do what you're told.
yeah. So I think Angela's has done a yeoman's job answering the questions. A couple things I might point out about your question here around community health workers is they too will be treated as providers. So there's both helping the family members set up the access to the information if they want it, or navigating them through it. And there's also the community health worker. In many cases, are registered nurses. They could be, they come from many levels and backgrounds, social workers. They could be medical assistants. But if they're acting as a provider, they would be able to have access to the patient's information through an HIE, if you will. So just as the physicians are granted access, and they too would also have access. But I would note something else, is that in all situations, families and patients are first going to their providers. Few are saying, well, I'm going to not go call my physician, I'm going to go to Chris and find that information. It's the HIE service pointers to the information as opposed to the information, because that's what they do. They move information and make it available at the endpoint. So what we're going to find is that families and patients will continue to use those providers as the starting source, and less inclined, if you will, to say, well, I'll just forget all that and I'll go to an HIE and try to piece it together. So, but it is, to Commissioner Stolenwerk's point and others, it is a huge first step into making HIEs much more consumer friendly and transparent about the work that they're doing. And the other thing HIEs noted is is that why it would be difficult to say thou shall do now as opposed to leaving them with the option is there's a technology component to this that is enormously expensive. And if we say, okay, now you all have to do this, it creates a burden to the HIE and a distraction from the work they're trying to do to make provider data available at the endpoint. So it's an evolution, and the journey has begun. And I think to Commissioner Stolenwerk's point, that's how you might want to think about it.
And I appreciate, your observation, but I really like your example because I think it's multiplied thousands and thousands of times. And along the way, when we talk about the evolution to this new platform, to not leave out the human touch, to prepare families, and to acknowledge that as part of the infrastructure that will help people make the transition. In the absence of that, not just your father, but many health disparity populations will be left behind. That's my concern. Thank you.
David, I'd like to follow up with a question. Following Commissioner Stolenwerk's inquiries, the circumstances under which a patient would be denied access by an HIE to their patient records. I'd like you to elaborate on that a little bit, because I'm really still, in my own mind, I'm not entirely clear about this. An HIE could, under certain circumstances, deny a patient access to their own records. What would be the legitimate reason for doing that?
So there can be a number of different reasons. I'll give you a few, but their gamut could be long. So the HIEs have to have policies established around disclosure. You could an HIE could potentially opt to the fundamentals of HIPAA, for example. If there's risks around information could be harmful to the patient, the patient could use it to harm themselves or others, the HIE would simply say, we're not able to disclose that information.
Would they do that in consultation with the patient's physician?
It could be in consultation, but I think the real piece here is that you're getting at is the sensitive health information, and Commissioner Phillips and I had a little bit of a conversation around that earlier today. As it relates to sensitive health information, which is where the rules of the engagement have been defined by SAMHSA all that well. And HIEs are saying, HIEs are required where there's sensitive health information to make it only available to a point-to-point transaction, meaning that data flows between the two providers as opposed to the HIE, and they offer the infrastructure to support it. That would be another case. And the issue of emancipated minors brings to light a whole other scenario. And in the case of Chris, between an individual where there's a child between 14 and 18, and let's say a parent wants to get that information, Chris has a policy that requires notarization where the child is also consenting to that release of information to make sure that the parent in some way isn't spoofing the requirement to get access to that information. So it's really the null of that is the issue here, is making sure you don't give information out when you shouldn't on the emancipated minors.
All right, emancipated minors is one thing, I can understand that. The minors, I can understand all that. What I'm concerned about is, I guess it's a broader concern. I am somewhat concerned about the fact that individuals who in fact have delivered in a medical interaction with a doctor or other medical professional, delivered some sensitive information. That information is stored in a health insurance exchange. They're concerned about this and they want to get it for some reason and it's denied. I want to make sure I understand this because it's a critical question. When a patient initiates the process of having that information go into the health information exchange, does the patient understand up front that there are certain circumstances under which that information would be denied them? So access to that information would be denied. Do they understand that up front?
So if you'll allow me to answer it a little differently again. So the HIE isn't going to give you your medical diagnosis. They're going to tell you where you can get it. They're going to say that Dr. Smith has the information and released it to Dr. Jones. They will not give you a descriptor of it was this test or that test or this result, which still keeps some of the confidentiality. And what they do is they point the patient to the endpoint to get the information. A lot of the medical information you're talking about today is not contained within HIEs because HIEs are very different. If you're hospital-based versus if you're a SureScript looking at pharmacy data, or if you're a CRISP where you're acting as a portal by and large to information. So the quick answer is patients are informed by the practice when they go into the practice. They can choose to, as Angela noted earlier, opt out because they're informed what CRISP does, the utility of it,
Right.
and the value of it, and given a chance to say, I don't want to be a part of that. And today, in Maryland, we have 6,637 opt-outs where consumers have said, I don't want to be a part of it.
Okay.
So now, do we expect that number will grow as consumers become more knowledgeable? Yeah, we do. When you think there's 9 million, 6 million some odd Marylanders, we're probably going to see that number rise over time as their knowledge grows.
The reason why I think Commissioner Sullenberg's questions were poignant is that there's a subtext to all of this, and I obviously we're not going to solve this problem here, but one of the great questions seems to me about health information and records and medical records and so on is the ultimate question about who actually owns the record. Because you have an interaction between the doctor and a patient. The question is, does the record belong to the doctor or the patient? And as I say, the Maryland Healthcare Commission is not going to solve this problem. This is not, at least not right now. But you and I have had this conversation in the past, and I think, frankly, it is a major public policy problem because, frankly, I don't think anybody's really solved it yet. I know at the federal level, they certainly haven't done it. There have been some proposals to create things like health records banks where people would basically deliver their health records to a bank for reasons of research or whatever, and they would actually get paid back, if in fact researchers actually use those records to conduct some kind of major research project and so on. But that's a separate matter. I don't want to delay this any further.
But Mr. Chair, if you don't mind, as these things get populated and people start using them, I don't think we should be blind to that on the de-identified level, population base, who they are by age, race, gender, and other demographics, geography. Are we at least able to see that? Are we at least able to see the patient population accessing or who have access to their electronic record on a de-identified population-based basis?
So the short answer is, since it's not happening today, we don't know that there isn't a process in place today that would say, run these reports, tell us the demographics, tell us where this is.
Do you think that the commission has a role to play in making recommendations along those lines?
Yeah, I think that's fair. I think that's a very good point, and something that we would want to engage more. We have a whole requirement in the regulations that you all have approved around secondary use of electronic health information. But I think looking at it from an aspect or utility of reporting is something we could look at.
Thank you.
Okay. Commissioner Phillips.
Thank you. I just have one quick question, and it relates to, I think, what could be a really exciting application of consumer access to an HIE record, and that's for immunization records for children. So I'm going to assume that the state still doesn't have a registry, a standalone registry. May never want a standalone registry, but for so many parents, it's such a hardship to go to try to reconstruct pediatrician, clinic, every year, every place, and to gather, comprehensive immunization record, which is necessary for every school year and for school nurses, for example. So when these regs are adopted, which I hope they will be, and rolled out, and I hope most, if not all of these 8 HIEs will see their way to offering consumer access, I would think that this would be such an advantage that they would really want to promote that just for that one purpose. It's not sensitive information, but it has great utility to families.
Yeah, and that's a great point. And I will tell you, there's been a lot of discussions at CRISP about immunization registry. So some of that thinking is already beginning to occur, and this will help enable that.
So along those lines, a school nurse, for example, or a community health worker could be a proxy for the parents
That's correct.
with their consent
Correct.
to access those records. That's going to be really super. That's really great.
Okay. Any further questions? Yes. Commissioner Stellenwerk.
Thank you. So
Here we go.
on the immunization piece, that would require the various entities to be part of each HIE, various entities that provide the immunization. So the interoperability or the sharing of information across the HIEs, because, you know, so if you want a full immunization record, so I mean, I love where Commissioner Phillips was going with this, but we really need to think about the practicality of how those connections can happen to really provide the value to consumers, which is a very important part of this process. The other piece too that I hope that we're able to do as a commission is let people know, let the public know about this. If these regulations get adopted, which I agree, I hope they do, let them know that this is now an option for the HIEs to choose to do. This could provide some impetus for the HIEs if they start hearing from their patients, consumers, their own constituents, if you will, about how important this is. But if nobody knows about it, they're certainly not going to be asking for it. And the HIEs aren't going to say anything about it if they decide it's not worth the hassle. And I'm still a bit concerned about sort of the all or nothing hassle factor here, that those who don't do it may choose to not do it because, as you mentioned, it's a costly process. So we need to make sure the public knows that the HIEs can choose to do this. And if they don't, it's because they're choosing not to give that access.
Good point. Thank you.
Okay. Any further questions? Okay. Do I have a motion to approve the adoption of COMAR 102518, Health Information Exchange, Privacy and Security Regulations? Commissioner Stellenwerk and Commissioner Carr York. Okay, thank you. All those in favor say aye. Aye. Any opposed? No. Congratulations. You have your final regulations, which are our final regulations.
Thank you.
You did the work. Okay, thank you. Okay. The next item is state recognition of electronic advanced directive service providers. This would be a release for informal comment for regulations. Nikki Majewski, the Chief of the Health Information Technology Division, will present an overview of these draft regulations regarding state recognition of electronic advanced directive service providers. The presentation is the prelude to the start of an informal comment period on these draft regulations for the Commission. At the conclusion of the informal comment period, the staff will consider those comments and then return to us here with recommendations for the adoption of the proposed permanent regulations. So there's no vote that is necessary on this today. This is just simply for the release of the draft regulations. But I would ask the commissioners if the commissioners will assent to the release of this informal public comment. Ms. Majewski, you have the floor.
Thank you. Good afternoon, commissioners. Before I present on the specifics of the regulations for the state recognition program of electronic advanced directive services, I wanted to provide a bit of background information as to how we got to this point. In 2011, the Maryland Healthcare Commission was awarded roughly $1.6 million from ONC to, among other things, pilot the exchange of electronic advanced directives. MHCC subsequently convened a focus group to assess technical and policy challenges with electronic advanced directives. And in general, the focus group concluded that a health information exchange was a viable solution to securely communicate information on end-of-life preferences. In back to 2012, the Secretary of DHMH at the time provided additional startup funding to support a pilot that would enable the exchange of electronic advance directives through the state-designated health information exchange. In 2013, MHCC issued an RFP to identify a vendor who could implement a statewide solution that would allow providers to query at the point of care advanced directives. AB Vault, doing business as mydirectives.com, was competitively selected to build an interface between its cloud-based service and the CRIS query portal, and that interface went live in 2014. During the last 3 legislative sessions, 3 bills were passed with the aim of furthering diffusion of electronic advance directives. House Bill 1106 was provided guidelines for witnessing requirements for electronic advance directives. House Bill 1385 formally tasked the Maryland Healthcare Commission and DHMH with the implementation of a statewide advance directives program. And key elements of those laws, it again altered witness requirements for electronic advance directives, expanded the scope of education and outreach required by DHMH, and then it required MHCC to develop a state recognition program for vendors to connect to CRIS. And lastly, this past session, House Bill 188, which was a cleanup bill of sorts, clarified the definition of advance directives and clarified that DHMH could contract with 1 or more vendors, and also established a specific advance directives fund that would be non-lapsing. So in terms of developing the regulations, MHCC and DHMH had convened 2 work groups, one of which was the Criterion Connectivity work group that we spearheaded, and they mostly focused on the criteria that would be used for recognizing vendors, as well as the application process. And then the Engagement and Special Issues work group was spearheaded by DHMH, and they focused largely on the scope of education and outreach. The work groups met during the fall of 2016, and the output from those work groups was used to develop these regulations. The key components of the regulations, which focuses on the process for state recognition of an electronic advance directive service. It outlines the process for developing the criteria for state recognition. It includes procedures for the application process at both initial and renewal. It includes procedure for contesting a denial of state recognition. Also included are provisions for the non-transferability of state recognition due to a closure, sale, merger, or lease. And then it also articulates MHCC's oversight role, including the process for investigating or revoking a vendor's recognition. So in terms of next steps, we do want to release these draft regulations for an informal public comment period. They would be received up until June 2nd. We would bring them back to the Commission next month in June for as proposed permanent, and then request for final action in September, with a final effective date being in October. Anyone have any questions?
I have a question. Tell me, what in fact is the consequence of being revoked for state recognition? What is the consequence of that for a provider who provides this? What does it mean realistically?
So essentially, a vendor could become state recognized, but may not be under contract with DHMH. So at least if they meet state recognition, we can say they've met national benchmarks for privacy and security.
Who sets the national benchmarks?
They're well established, just around HIPAA and all the
HIPAA.
basic kind of privacy and security stuff.
Okay.
So I think the impact would be larger if we did have a recognized vendor who was contracted, which would be part of that portion of that fund going to connect that vendor to Chris. So that would probably be a bigger issue. I mean, we don't pretty much, I mean, there could be an issue where we have to revoke a state recognition, but as long as they maintain compliance with the criteria at the time that they apply.
If it's revoked, the consequence is not being able to connect to Chris, right? They would still do whatever else they do. I mean,
Yes, they can operate. I mean, a lot of these vendors are out there right now. My Directive technically is, out there right now, and you can create. It's just not being state recognized and enabling that service to increase the push of those at the point of care through Chris.
Any further questions? Okay. I would like a motion. Yes. Commissioner Sargent.
and I'm sorry to. Do you have an idea of like how many of these folks there are? Is there like, how many services we might expect? Is it going to be heading towards one big statewide service, or 80 advanced directive services all competing? Something like, I don't have any view of what whether there's a marketplace or what the marketplace is.
Well, we did do an environmental scan back early last year in 2016, and we did identify some vendors who, it's really only a handful that are probably ready to apply for state recognition in the sense that they really could meet these benchmarks. There are some that are still developing, and some that are mostly focused on MOLST but are developing an advanced directives platform, so they're evolving, but we would envision that there's probably not going to be a big number applying for state recognition. And then, of course, the contracting part would be limited on funding available. So whoever is it.
Okay. Yes.
I don't think that we're going to see a large number of vendors coming into this marketplace at this time. And there's some question, and some of you may have been asked by your primary care or usual provider about making your advanced directive available to them. I think it's more likely that over time, EHR vendors are going to integrate these advanced directives, and Nikki made reference to MOLST, which is a medical orders for life-saving treatment, which is a more detailed, specific set of orders that providers argue are operational at the point of care regarding appropriate treatment that the patient wishes to receive, that they would be part of an EHR that would then be, as EHRs have to be interoperable, would be automatically accessible. It's my view, I don't know if the staff's view, is that the advanced directive repositories may be an interim solution to the challenge of getting advanced directives and other advanced care directives out of safe deposit boxes and bedroom drawers or wherever they're held, and make them accessible to providers. I'm sure most people, have seen someone coming in from a nursing home if you visit hospitals with the advanced directive is actually laying on the patient's stretcher with the patient, and is that the most recent, et cetera. So there's a lot of questions about the reliability on the part of providers. I have a acquaintance whose father had 3 advanced directives, and the providers of care opted to question all of those because they weren't sure it's current. So I think this is a good step forward. What is the final solution in terms of how we're going to share this critical information? I don't think so, but I think the department has been since 2006 required to establish a registry and make available a framework. And we're very pleased to provide some of the technical advice on the advanced directive vendor front.
Okay. Any further questions? Okay. Do I have a motion to release the draft regulations for informal public comments. Motion. Commissioner Flagg, Commissioner Carr, your work. Okay, thank you. All those in favor say aye. Those opposed? Thank you. The ayes have it. Okay. All right. Well, the next item, ladies and gentlemen, has to do with the state health plan for facilities and services focused on general surgical services. Ms. Fleck was supposed to do it, but it looks like, Mr. Parker, are you doing this?
I am.
Oh, very good. Okay. The script is wrong. Okay. Mr. Parker, Paul Parker, will provide a brief update to address the issues that were raised by the Commission at last month's public meeting on the draft state health plan for general surgical services. Paul?
Thank you, Chairman Moffett, members of the Commission. So this is a follow-up to last month's meeting. At that meeting, we reviewed a new draft state health plan chapter covering general surgical services and facilities, and that was tabled after a very interesting discussion by the Commission of that draft. So we are taking that input, and we're going to do some further development on this question. I'd like to start off by kind of reviewing for Commissioner Wang, our new commissioner, and just to make sure everyone's kind of understanding the context here, where we are. I'm going to review some of the questions that were raised at the April 20th meeting, answer a couple of them, talk a little bit about what we're doing to try to answer the other ones, give our view of what our sense of the Commissioner's preferences are from that discussion and what that implies in terms of policy changes, and then the process going forward. So where are we currently? Under statute and the regulations that we've developed in our state health plan today, a certificate of need is required to establish any ambulatory surgical facility. And in Maryland, that is a facility that has 2 or more operating rooms. So there is a provision in state law that allows development of smaller facilities with 1 operating room, or indeed without operating rooms. Facilities can do operative procedures in non-sterile procedure rooms. So we have a lot of those in Maryland that we don't regulate, but you need a CON to establish an ASF. You need a CON, of course, to establish a hospital, which is the major provider of surgical services in the state. You also need a CON to add operating rooms at hospitals or ambulatory surgical facilities. And in both cases, our state health plan really uses some quantitative standards on OR operating room capacity to actually evaluate the need for these projects. So in general, our standards require that applicants be operating at a specified hour volume level in their operating rooms, which we assume to be full capacity, or as we call it, optimum capacity, which is 80% of full capacity. And then we also require applicants to provide a demonstration of what their plan is going forward for the new facility or the expansion, so that we can see that they're actually going to reach those high capacity levels, what we consider to be reasonably high capacity levels within a short period of time. What we reviewed with you last month would be changes that would attempt to exploit a feature of the statute that we have not tried to exploit before, and it allows the Commission to actually have a more abbreviated review process for facilities that want to actually have a 2 operating room ASF at the end of the day. So the changes we proposed are to allow existing 1 operating room facilities, which we call physician outpatient surgery centers, to add a second OR through an exemption process rather than a full CON review. Also, we would let 2 1 operating room physician outpatient surgery centers consolidate through an exemption process to create a regulated facility, a 2 OR ASF. and also freestanding medical facilities, which would be created by conversion of a general hospital to an FMF. We would allow the hospital involved there to also seek an exemption so that they could have an ambulatory surgical facility, again, because of the statute, a 2 operating room ambulatory surgical facility that they would operate in conjunction with their FMF. So in effect, retaining some of the surgical capacity in the general hospital that's converting. We maintained the same operating room capacity assumptions in this new version of the plan. The small 1 operating room facility that wanted to expand with a 2nd operating room would be subject to the same requirements. We would expect them to show that they've met an optimum capacity level to qualify for an exemption. And we would expect them to demonstrate that they can use the additional operating room capacity at optimal capacity. For the other 2 exemption options, the consolidation and the FMF-related ASF development, we did not have a threshold level that they had to meet in order to enter the exemption review process and get consideration. But we did apply the same assumptions going forward. We wanted to see a demonstration that they would be using their proposed operating room capacity at optimal capacity within 3 years. So the next couple of slides summarize what we thought were the key questions raised in the discussion last month. I'm not going to go through all these. I'm going to try to give you some information on a couple of these. Before I proceed, one thing that isn't listed here, because it's not really an open question, but it did come up in the discussion, and that has to do with health maintenance organizations. As probably some of you recall, we have had Kaiser Permanente develop and expand several ambulatory surgery facilities in the state in recent years. Under current law, health maintenance organizations are exempt from CON review when they develop healthcare facilities that would otherwise require a certificate of need if the facility is going to be exclusively used by the HMO membership. But there are 2 exceptions to that in the law, and those exceptions are establishing a hospital or establishing an ambulatory surgical facility. So that's why Kaiser's on the hook and has to come to you to get approval when they build ambulatory surgery facilities or expand them. So that might be something that you might want to consider as far as a recommendation on a statutory change if you really feel you want to exempt HMOs, basically expand the exemption that already exists in the law to a more broader exemption. That might be something you want to do. And the other issue I wanted to address, actually kind of the last bullet point here, and I believe this was Commissioner Sargent who raised it, has to do with charity care requirements in our state health plan. Generally, we do not have requirements for the provision of a specified level of charity care in the facilities we regulate under Certificate of Need. We generally do require that they have charity care and financial assistance policies in place that meet certain requirements. But the exceptions in our state health plan are ambulatory surgery and the standards for intermediate care facilities for alcoholism and drug abuse treatment. And Commissioner Sargent rightly pointed out that that's a fairly unique state health plan standard, the ICF chapter, because it does impose a fairly high charity care requirement on certain types of intermediate care facilities. The other exception in our state health plan is ambulatory surgery facilities. In 2012, when we adopted the plan that's currently in place, because ambulatory surgery facilities are minimal providers of charity care, we did propose that anyone becoming an ambulatory surgery facility, and most of the applications of this type we see are actually existing 1 operating room facilities that are busy and are graduating to a regulated 2 operating room facility. We did impose what we thought was a fairly easy standard to meet. and that would be that they commit to provide the most recently reported average level of charity care among ASFs in the state, and that's typically been around 1% in recent years, or slightly less than 1%. In the case of ICFs, the reason why we have this much higher charity requirement, and there is some flexibility on that, it's 15% for the type of ICFs that are privately funded. So it's long been recognized in our state health plan, and this is an old state health plan and policy, that that this is a unique facility. Unlike everything else we regulate, we don't require Medicaid and Medicare participation by these types of facilities. And I wasn't around when this approach was initially developed, but I think the reason is that the commission did not want to close off the development of the small number of facilities we see in Maryland that have a fairly standard 28 to 30-day treatment program for alcoholism and drug abuse, and are providing a high level of treatment, because that's really the only level we regulate, medically monitored inpatient treatment. So we do have a number of facilities in Maryland that basically are private pay. They don't participate in Medicare and Medicaid. Medicare and Medicaid reimbursement policies would not come close to providing the type of reimbursement that they typically want and need to support that type of program development. So it's been long established that when those types of facilities want to do something in terms of a capital project that requires CON review, that they commit to 15% of their patient days being provided, not as charity care, but as what is referred to in that plan as indigent or gray level. And that's basically people who, on an income basis, would qualify for Medicaid. And there's nothing preventing these facilities from participating in Medicare and Medicaid if they want to, but they do have to commit to a fairly high level of service to lower income people. And they do have the flexibility to demonstrate why 15% isn't the appropriate level for them and some other level is. And we have reviewed and approved projects that have committed to other levels. So again, the takeaway here is generally we have not gotten into this area of requiring specific levels of charity care, but that is a very exceptional and very different type of service that we regulate in that way. Now, to get to some of these issues, the next couple of slides are putting the optimal capacity assumptions that we use in the state health plan now into some context. So we're trying to show you, how does that really comport with the actual reality of what we see happening in hospitals and ambulatory surgical facilities. So this first one is looking at hospitals, and for hospitals we use 1,900 hours per year per operating room as an optimal capacity assumption. And so if you look at those last two rows in the table, you can see that somewhere between 10-11% on average over this time period of our hospitals are actually reporting use levels in their operating rooms that are at that optimal capacity level or higher. So in any given year, that would be kind of the proportion of hospitals that would be able to kind of approach with a CON application and have kind of a prima facie case that they might need more operating room capacity. And then this is looking at ambulatory surgical facilities, and in this one, it's about 10 to 15% over this period of time are falling into those last two rows, which are optimal capacity for ambulatory surgery. That's a lower standard, 1,632 operating room hours per room per year. And I would have a bit of a caveat here. This is a MHCC survey. This isn't from the HSCRC discharge abstract, which is what we're using for the hospital information. And we're just telling you who's reporting this level of operating room use. There may be some of these facilities, and I'm fairly certain there are some of these facilities in that bottom row that are reporting some fairly suspect numbers because the numbers are so high. They're reporting numbers of hours in their operating rooms that seem pretty questionable in light of what the typical hours of operation are for an ASF. So even though we're kind of in the 10 to 15% range, I would guess we're probably closer to 10% in any given year are realistically reporting being used optimally, and therefore, could gain entry under our current plan for additional operating rooms. Payer mix. This is actually a better set of pie charts than we provided to you last month because we've done a better job of kind of drilling down on outpatient surgery charges in the hospital. So you're seeing charges in the hospital setting on the first pie chart, and then it's not an apples-to-apples comparison because we're not able to do that, but we are showing you percent of total net revenue being reported at non-hospital surgical facilities. Both of these are for calendar year 2015. So you do see that big difference in the Medicaid proportion, 16% on the hospital outpatient surgery side, only 4% on the ambulatory surgery facility side. Geographic distribution of ambulatory surgical facilities and the smaller facilities, the physician outpatient surgery centers. Not unexpectedly, very heavy concentration along the Interstate 95 corridor, which is where most of us live. I provided a table that I haven't reproduced here, but on your commissioner page, there was also a table that accompanied this map. And if you look at the counties that have the most ambulatory surgery facilities, what we noted there, Montgomery, Baltimore County, and Anne Arundel, those are all large jurisdictions. They comprise about a little over 40% of the total population, and they have about 52% of these ambulatory surgical facilities, closer to 60% of the total operating rooms in these 9 non-hospital settings. And socioeconomics, I think, clearly comes into play here because if you look at Baltimore City and Prince George's County, on a per capita income basis, those are much less affluent jurisdictions than Montgomery, Baltimore County, or Anne Arundel. Those are all in the top 5. I think Baltimore City and Prince George's were like 16 and 17 out of 24 jurisdictions in terms of per capita personal income. They have much fewer ambulatory surgical facilities. They're about 25% of the population, but only about 12% of the facilities. And then we do have 5 jurisdictions in the state that do not have any ambulatory surgical facilities of any type. In the far west, Garrett County, and then the other 4 on the eastern shore, Kent, Caroline, Dorchester, and Somerset. So they're small population, collectively a little over 2% of the total population. 4 of those counties do have hospitals, so they're not bereft of a surgical provider. Caroline is the one that does not have a hospital currently. So what did we take away from last month's discussion? This is our summary of kind of commissioner preferences on the issue, which was the primary issue of discussion, which is, the need standard for looking at surgical facility projects. So we came away with a sense that the commission wants us to minimize regulatory barriers for developing surgical capacity in non-hospital settings because they're lower charge. So that would include both hospitals and I think Dr. Pollack actually said, he would like to see us try to the maximum extent possible under current law, try to minimize those regulatory barriers. We see kind of 2 main ways to go about that. Reconsider use of capacity assumptions in need determination, and add features of the state health plan that will facilitate the ability of hospitals to establish ambulatory surgical facilities, and thus shift outpatient surgery from a higher charge setting to a lower charge setting. So as a policy priority, our takeaway is that we're looking to come back to you with a plan that maximizes the ability to perform outpatient surgery in the lowest charge setting, which is the ambulatory surgical facility. And then in terms of using these capacity standards that we have traditionally used, at best, those should maybe be a secondary consideration in evaluating certificate of need applications. So the policy changes, they reflect commissioner preferences. This is just an idea of what we would want to discuss with our stakeholders going forward. Eliminate use of the OR capacity assumptions in considering the need for ambulatory surgery facility projects. Not necessarily for hospital projects, because, you know, the flip side is maybe you want to continue to have the same sort of rigor because you really don't want to encourage development of hospital operating rooms. We want to really prioritize development outside of the hospital. And perhaps one approach to that is to outline some way for applicants to demonstrate that they're going to efficiently use their operating rooms rather than using a set of specific quantitative standards. Number two, retain exemption reviews as we proposed in April 27. So you know, keep all those in the plan going forward. Expansion of physician outpatient surgery centers, consolidation of those types of facilities, allowing an easy path for hospitals converting to FMS to also have an ambulatory surgery facility. But of course, we would be looking at those exemption review processes to not necessarily use the operating room capacity assumptions the way they were in the current draft, and add an exemption review process allowing for hospitals to establish ambulatory surgery facilities when they can do so without increasing their overall operating room capacity. And again, that would be an approach that we think the current law would dictate. So what are the implications? We think Maryland might see some growth in the proportional use of non-hospital settings for outpatient surgery if we make these changes. We may see an increase in the number of 2 operating room ASFs and ASFs that are owned and controlled by hospitals. Shifting OR capacity and use from hospitals to hospital ASF, I'd say it's more than likely it will reduce charges paid for outpatient surgery. The caveat there, and you know, this is based on our discussions with HSCRC, is that it may not result in significant system savings or the amount of savings that you might hope for. Hospitals will still need to retain some revenue for the fixed costs and the overhead that are associated with the surgical facilities they already have in place. Essentially, it'd be retiring use of surgical facilities that they've already built and are paying for, and replacing those or substituting an ambulatory surgery facility for those. And this would be something that actually, under the current regulatory process at HSCRC, would be looked at on a case-by-case basis. Hospitals would be basically informing HSCRC that, hey, we're going to build an ASF. We're anticipating that that's going to shift, you know, this amount of outpatient surgical revenue out of our hospital and thus out of our regulated global budget into a non-rate regulated setting. So HSCRC would be making adjustments in that budget, but frankly, it's been kind of a case-by-case negotiation on, okay, well, what do we need to retain to cover our overhead and fixed costs? And we actually have talked with some examples of that with HSCRC staff, and in some cases there weren't significant system savings. In some cases there were system savings. In some cases hospitals kind of made a mistake and kind of didn't give HSCR a heads up, and they pretty much lost all the revenue. So there were some system savings there. But I think clearly going forward, if we want to make these sort of changes, I think we're talking about a certificate of need process that's more closely coordinated with what HSCRC does when those project reviews involve hospitals. And that's something that's actually been occurring anyway on hospital project reviews in recent years because of the new payment model. And what I suggest here is that maybe one of the things we could do in a state health plan is actually require that if we're going to see these kinds of fast and fairly easy review processes for hospitals who are substituting hospital operating rooms for ambulatory surgery facility rooms. In order to get those lower charges, we should require that there's a showing of system savings as a result of those projects. And again, collaborate with HSCRC staff to kind of validate that that's what we're going to see. And then finally, hospital ambulatory surgery facilities. I don't have a good answer for this one, but they're unlikely to have the same payer mix. As you'll recall, a few minutes ago, we reviewed the differences in payer mix between the hospital settings for outpatient surgery versus the ambulatory surgical facility settings. You might be inclined to say, oh, well, let's just require hospitals, if they build ambulatory surgery facilities, to maintain the same levels of Medicaid, Medicare participation. We shouldn't see a change in their payer mix. But of course, the problem with that is that if you want hospitals to successfully compete in this arena of ambulatory surgical facilities, you'd be really hobbling them in some ways, because those requirements would not be applicable to non-hospital providers of that service. So the process going forward, we have scheduled a meeting of our surgical services work group that we've already been working with previously to develop the draft that we brought to you last month. We're going to be meeting June 1st. I think the meeting is at 11 a.m. Welcome any commissioners who want to take a long lunch break to attend that meeting. You're welcome. We usually have the ability to dial in and listen, but we welcome participation. So we want to get their feedback on the new direction I've outlined here, and try to develop a new draft proposed State Health Plan chapter that we can bring back to the Commission at their July meeting for consideration. And then, of course, down the road, I think we might want to consider what sort of statutory changes you might want to suggest to the legislature on this particular area of regulation under CON. Again, under current statute, we pretty much have to kind of stay within that ballpark of 2 operating rooms, but you might want to think about expanding that, for example. So we've had 4 projects we reviewed already in fiscal year 2017, surgical facility projects. None of those would actually be affected by these changes, because they weren't 1 operating room going to 2. They were 2 going to 3, or 2 going to 4. So there are other types of surgery projects we review, and some of the same logic you might want to apply to those, but under current statute, you just can't do it. So that's my update. Be happy to answer any questions anyone has.
Thank you. Commissioner Thomas.
It sounds like such a great idea. So what I want to know is, based on your experience, who could possibly be opposed to this? What stakeholders are opposed to this?
I think there's kind of the general thing that happens with certificate of need regulation. These kind of changes are scary to people. I mean, this has been a highly regulated area for 40 years, and that regulation hasn't changed that much in 40 years. So if we're basically saying, and I think we would be saying, it's going to be easier for ambulatory surgery facilities to add OR capacity. It's going to be easier for hospitals to move quickly into, really being substantive players in the ambulatory surgery facility area. I think people who operate ambulatory surgery facilities might not be that happy about that. They may feel like the hospitals were, again, maybe skewing toward the hospitals, giving them some advantage over their ability to operate in this business.
And will this open the door to out-of-state providers?
The door's been pretty wide open in terms of one-OR facilities. And actually, I'd say one of the things we've seen over the last, 10 to 15 years, as opposed to the years before that, we used to see groups of physicians, or sometimes even individual physicians, were the developers of these small ambulatory surgery facilities, one operating room facilities, or basically procedure room type facilities. In the last few years, we've seen a number of national operators of ambulatory surgical facilities coming into Maryland and joint venturing with physicians and developing one operating room facilities and very aggressively adding a lot of specialties in that area and kind of rapidly and aiming rapidly to kind of fill up the hours at that single operating room and then go for an expansion to a 2 operating facility or 3 operating facility. So, that wasn't something that they were doing before, but in recent years, I think they like Maryland. It's an attractive market, and they're willing to kind of go for that development pattern that they're kind of limited to following in terms of our regulatory process. So we have already in Maryland national corporations whose business is operating ambulatory surgical facilities.
Thank you.
Commissioner Stellenberg.
Thank you. So the fact that they're lower cost is wonderful. That's what we're all trying to achieve with the healthcare system, in addition to protecting the safety of patients and the quality of care. So it'd be very interesting to see the relative safety of the ambulatory surgery facilities versus surgical or surgeries in hospitals. Personally, I don't make an assumption one way or the other because I can come up with reasons why one might be safer than the other, and I can flip it around and think why the other might be safer. So it'd be very interesting, I think, to see what the relative impact is on the safety. But back to the affordability issue, it really struck me when you mentioned that there are far fewer per capita ambulatory surgery facilities in the lower income counties, in Prince George's and in Baltimore City, and the fact that ambulatory surgery centers on the whole take far less Medicaid in their payer mix. I'm not sure what we can do about that, but it concerns me, particularly as a lower cost, more affordable option for individuals who may or may not be on Medicaid, but still may be at an income where they are shouldering more and more the burden of the actual cost of the surgery. So it leaves me suspect in terms of some of the actions of the ambulatory surgery facilities to really serve the full population. And we should be careful not to give benefits to higher income counties and ignore the fact that the lower income counties are not realizing the same benefit of a more affordable service.
Commissioner Phillips.
Thank you, Paul. Thank you for distilling our discussion last month and telling us what we talked about in a very rational way, so we can kind of move forward from there. So that in and of itself is a great benefit. I want to a little bit pile on to what Commissioner Stellenberg just said about this geographic distribution. So if I'm a low income, price sensitive resident of the Eastern Shore of Western Maryland, and I want to get a colonoscopy or I want arthroscopic surgery, I don't have really a choice. I'm going to pay rate regulated, I'm going to pay retail. I'm going to pay for those services to be provided in a hospital setting, whereas in more affluent areas, I would have a choice. I would have a choice of what the price, I would have real price choice, because the range of what those procedures cost to a consumer in terms of a copay or against my deductible is a very, very wide margin. So my question, saying all that, is there a way that we can incentivize through our levers the development of non-hospital or hospital ambulatory surgical centers to go where the need is, to go where we've got some pretty significant geographic gaps? I mean, it's a thought. It's a policy consideration that maybe the work group could pick up along with the others. But I just see an inequity here that will actually grow because Medicaid. I don't know why Medicaid is so price insensitive. Maybe not Medicaid directly, but the Medicaid MCOs. Why, if you're buying colonoscopies, en masse, why are you buying them in hospitals when you could hire a limousine and take people up to Green Spring and get them for 1/3 the price than you're going to have to pay in a city hospital? So I just see that it's not just consumers, but it's likely to be payers in the future are going to be much more price sensitive too. And so anyway, you got my question.
Yeah.
Thank you.
And I don't know that we have a strong lever. I would say we don't. Obviously, one of the things we're talking about here is to make it perhaps easier for hospitals who are assessing their own market and want to build ambulatory surgery facilities themselves, and therefore actually, implement a business plan in which they would get paid less for the same thing that they're getting paid a lot more for now in the hospital setting.
That's in the short term.
But that's not much of a lever in these counties we're talking about here, because those are the very hospitals who aren't that worried about competing with ambulatory surgery facilities, because there aren't any competitors out in those areas. So they're unlikely to kind of see the value of that approach. One of the things we have to keep in mind too when we look at a map like this is that it really represents not years of actually regulating the distribution and supply of facilities. This is largely a map that's produced without CON regulations providing any guidance.
Market produced it.
Yeah.
Right. Yeah. So the question is, from a regulatory standpoint, can we address some perceived failures in the market in terms of equity? That's really kind of what the challenge is.
Right. I think that will be a real challenge for us, given the tools we have.
Yeah. I'm not going to say anything. Commissioner Sargent.
Thank you for, thank you. It was very informative. I appreciated all the facts, and thanks to Commissioner Phillips. When I turn 50 this year and go for my colonoscopy, I'm definitely going to take a limousine. I said, when I go for my colonoscopy after turning 50 later this year, I will definitely take a limousine. Thank you for the image there. One thing I recall from our last discussion, the current requirement to meet the certain number of projected hours to get the exemption was intended really that if you don't get the exemption, you go through the regular certificate of need process. I suppose one thought might be, rather than eliminating it, putting it at some low level, like if you can't show that much hours, there's something fishy and we have to look more deeply. Like, I'm not sure, there might not need to absolutely get rid of it as much as push it down. It looks like for the levels we had, like 80% of existing facilities were below the amount we were required to get the exemption, and that just seems to be way too high. But if you said, well, you have to meet the number of hours, say 25%, the top 75% of facilities in order to get the exemption, or we're a little concerned. For me, at least, I can see somebody doing a reasonable line drawing there. I would ask when that comes back, why did we draw the line there, and what is our concern? But it does seem like there might be a middle ground to think about. And on the charity care, that was very interesting. So do I take it then on the detox facilities with their 15%, if they took Medicare, Medicaid, they would pretty much meet the gray market requirements through that?
It would certainly seem that it would be fairly easy for them to do that, yeah.
So the real shorthand version would be everybody else winds up having to take Medicare, Medicaid. They don't in that category, and when they originally did the regulation, they put the gray market in because of that, and that would have been the rationale of the people at the time, the commission at the time. That's
right.
Why that was not singling them out necessarily.
So I would say that right now, if you're relying on Medicare or Medicaid as a payer for alcoholism or drug abuse treatment, you're pretty much looking to the facilities that do participate in that, and they tend to be facilities that are not providing a 28-day inpatient or residential stay. That's not the way their program operates. They're doing intensive outpatient treatment, maybe some residential treatment, but at a much shorter time period at a lower cost. And that is the majority of program types that we see. It's actually a fairly small sliver of the provider programs that are out there that are the expensive inpatient programs.
Thank you.
Just one, I'm curious now. Based on your experience, what might be one or two unintended consequences of this? And we have the letter of the law kind of the thing, and then we have all the creative flexibility that one might apply to it. What might be an unintended consequence?
I think that's the first time somebody's asked me to come up with unintended consequences. But I'm really not sure. I mean, you know, I think what I've tried to point out is that.
So you think this is all good for the consumer?
You know, I think I pointed out here that you know, going in the direction I outlined here. So if we actually end up with a lot more than we have now, I think we have maybe 10 ambulatory surgery facilities in the state, 10 or 12 that are either owned and operated by hospitals or in which hospitals are principals, you know, in a joint venture with physicians, for example. If we have a lot more of those because of regulatory changes of this type, so hospitals become much bigger players in the non-rate regulated ambulatory surgery field. What I'm saying is that, you know, if we don't put any sort of barriers to them kind of regulating on a level playing field with everyone else that's doing ambulatory surgery, you know, we would be promoting kind of like two tiers. You know, we'd have the Medicaid patients, not necessarily Medicare, but Medicaid and uninsured patients, they'd be getting surgery in the hospital setting. And you would see the commercially insured and the Medicare patients basically having the option of getting their surgery in the outpatient surgical facility setting. So I think there are real issues with that. I don't think that's a good thing. And that's obviously something that I think in general our policies have tried to discourage. But I don't have a good answer for how we, you know, how we get the benefit of maybe shifting out of a higher charge to a lower charge setting, but avoiding that as a consequence.
I guess the question I have with that, though, is I think we have to be careful because we only have the certificate of need. You might say if you set it up so that Medicare and commercial insurance and everybody but Medicaid is doing this more cheaply and more efficiently, sooner or later, the people in Medicaid will change their rules to take advantage of the better situation. Instead of our looking at the beginning and go, we can't allow that efficiency to occur because it will be unfair to the Medicaid people. Maybe the pressure should be on the people running the Medicaid system to try and put in a set of rules that work more efficiently.
Okay. Ben?
So I think we're still somewhat, we're still gathering data on the Medicaid population, why they're ending up in hospitals. Is it the reluctance of existing surgery centers to contract with MCO, or is it some sort of inherent preference in the Medicaid program, or is it the Medicaid population eligible for these types of surgeries are more appropriately treated in a hospital setting? So I don't think I think that's unlikely, but I would want to. I think we need to drill down. We have made some inquiries to both Medicaid, the Medicaid administration, and to several leading MCOs about their ability to contract with ASCs. We should have that information back to the commission by next month. It's been a little slow in coming. I would say one, I don't know if it's unintended, but it goes back to the point that we have pursued an implicit policy of encouraging small ASCs over the last 30 years because of the ability under current law to establish a one OR facility through a certificate of determination of non-coverage of CON, sort of a oxymoron there somewhere. So if you're not covered by CON, you can establish a one OR facility. We have, as been noted by Eileen and Paul today, more OR facilities than virtually any other state, regardless of size. But when you actually count ORs, we come down into the expected range. So I think the pressure will be, if we go in this direction, keeping in mind that hospitals are swapping out expensive capacity for less expensive capacity. Nevertheless, there would be some pressure on some of these smaller ORs and surge facilities. I've had some questions about, what is the quality in smaller OR facilities just generally. I think independently of this initiative, we need to move forward on. I know that Teresa and Eileen have had some conversations with commissioners and are working up a plan on how we go forward with that at the same time, which is related but independent of what we're talking about today.
Maureen.
Thank you. I think that what we're seeing with the ambulatory surgical centers is such a multi-tiered reasoning for why they're proliferating, and our director has just raised some of the reasons why. And one of them is it suits a particular portion of the population very well. They tend to be located in more suburban areas. They're easily accessible to people who have automobiles and can drive there. They're convenient for surgeons in that they don't take emergencies, so you're not going to get your case bumped. You're not going to have to, wait another 3 or 4 hours because an appendectomy and an emergency C-section and heaven knows what else came in while you and your patient were waiting. And because it's a controlled environment from the point of view of both the patient, at least the sophisticated patient, and the physician, in that you know where you're going, you know what you're getting done, you have everything pre-selected, and you leave. And I think it suits them very well. If there's a way to make an ambulatory surgical center more attractive to other populations by adapting the model a bit, then that might, I think, make it more prevalent in the cities, in currently more underserved population areas. But you've always got to also take into account the tendency in some of those areas to more complicated patient profiles, such as Ben alluded to. And I think that's a big part. And I'm not sure regulating is going to solve that, or is going to, I think what it's going to do, if we're not careful about how we do it, is it's going to lose us the cost savings we're currently getting without getting a concomitant increase in overall quality.
Commissioner Sullenberg.
Thank you. A request that seems simple, it may not be, but Ben's comments about gathering information or to find out why the low Medicaid utilization, because I would imagine any number of people on Medicaid would also appreciate the convenience and also appreciate the affordability and so on and so forth, and the predictability and such. So finding out what the barrier is. So thank you for pursuing that. That's a really important information for us to know. And then the other piece, even though there's a longer term exploration about quality and being able to look at the relative quality with ASCs versus surgery and other settings, if you have information that's available sooner, it would be really, I think it would be helpful for us to see that as well. Because as we know, the issue isn't just about cheap. We also want to make sure, and I use that word in particular, it's not just about being as less expensive as possible, because you could do something really shoddy, extremely poor quality, lower cost, and that's not what we're looking for. So if there is data about the relative quality of surgery that's conducted in ASCs, surgical infection rates, that kind of thing, versus hospitals, if you could share that with us as well. Thank you.
Any further questions at all? Paul, thank you for an absolutely terrific overview, and we look forward to the product, the new state draft next month. Thank you so much. Commissioners, we skipped over agenda item 2, which was the update on the commission's activities. In the interest of time, we're going to go back to that. You all have received these written updates from the various centers, and you've had an opportunity to read them. So, commissioners, I just want to ask you a question here. Do you have any questions about anything that's in the updates? Anything at all? Nobody. All right, Ben, do you have anything that you want to tell us?
So I have just one announcement. I wanted to be sure the commissioners knew that our work with the Rural Health Work Group continues. If our Director for Government Relations would be here, she alert you, but she's recovering from hand surgery. So the next segment of this effort is public hearings, which will be occurring beginning on May 24th in Chestertown and running through Caroline County on June 13th. We have hearings scheduled on June 1st in Dorchester, in Caroline, as I said, June 13th, in Queen Anne's on June 6th, and in Talbot on June 12th. All of these are scheduled to be from 6 to 8 o'clock at night. Commission staff will be participating in organizing those hearings. We will expect that our contractor at the University of Maryland School of Public Health and the National Opinion Research Center at the University of Chicago will come to brief you in July on some of the early findings from their studies, from their work, and with the goal of having the report to you in the fall. Naturally, there is the Rural Health Work Group will have a chance to put their mark on it before it comes to the commission. Once the commission sees it, then you would act on it, and we would then submit it to the governor in the late fall, early winter. That's all I have.
Okay. Is Teresa available?
Teresa is ill today, so
okay.
Just very briefly,
Yeah.
she has been working very diligently with Leapfrog, and they will be holding that webinar with the hospital to talk about incorporating Maryland hospital results into the Leapfrog patient safety initiative and the surgical volume efforts that Leapfrog has launched. We've noted, and that few Maryland hospitals participate in Leapfrog, principally because of limitations in the Medicare data that Leapfrog uses. MHCC and Leapfrog have developed a workaround using hospital discharge data that we think will enable the state to have good information that's consistent with what's reported nationally, and that webinar will be aimed at engaging hospitals in this effort.
Thank you very much, Ben. David, could you give us an update on the grant application to the PCORI, the Cybersecurity Readiness Program assessment tool that they're developing?
Sure, it's my pleasure, Mr. Chairman. Good afternoon again, Commissioners. In collaboration with the University of Maryland, Lorien Health Systems, Howard County Health Department, and CRISP, a grant application was submitted on May 17th to the Patient-Centered Outcomes Research Institute, as the Chairman noted, PCORI, to examine the effectiveness of telehealth for transitioning patients from a skilled nursing facility to home as compared to the traditional comprehensive care approach. PCORI has made available a total of $9 million that will be dispersed to grantees over a 4-year period. The University of Maryland is the prime in the application, and award announcements are anticipated in November. I would like to thank Angela Vad and Justine Springer on our team here for their hard, diligent work over the last 4 or 5 months that really brought this thing to submission. So I applaud them and their work. Lastly, Mr. Chairman, to the second point you mentioned, in your handout today, you'll see this document. It's a cybersecurity cybersecurity self-assessment readiness tool. It's a lot to say at one time, which is intended to assist small providers with assessing cybersecurity readiness. The tool consists of a series of self-evaluation statements using elements from the National Institute of Standards and Technology, the cybersecurity framework. The tool was developed in collaboration with members of the stakeholder members, including the Maryland Hospital Association, MedChi, Lightspan, and Health Facilities Association of Maryland. Here again, I would like to just thank all the stakeholders and Justine Springer, who was point in putting this together. It looks simple, but it took a long and tedious pathway to get to this point. So I'm excited to see it provide value to healthcare providers in the state. Mr. Chairman, that concludes my update.
Thank you very much, David. Does anybody have any questions for David? Thank you very much, David, as always. Thank you.
I do have a brief question for Ben.
Yes.
On the rural health. Will those forums be videotaped, broadcast, or anything like that?
We've had some luck, or lack thereof, on the shore, given the limitations of Wi-Fi, but I'll get back and share with you an answer. They may be simply dial-in access. You can hear people.
Okay.
But not.
Okay. Thank you.
Okay. The last item is an update. Rather, really looking forward to upcoming initiatives. Mr. Director, fill us in.
I missed my opportunity at the start. I wanted to officially welcome you as chairman. I'm Calvin Staff. We look forward to working with you. Your perspective and good humor are highly valued by part of all the staff. And we're a very successful service with you as chair. We also want to welcome our new commissioner, Commissioner Lang, to the commission, and look forward to bringing him up to speed and working with him in the future as well. In terms of our June meeting, we have a couple important reports one important report that will be coming out. Linda Barnitz's team will be reporting on the privately insured with a focus on the individual market. There's enormous interest in the individual market in general. There will be significantly greater number of comparisons of those individuals who purchase on the exchange versus off the exchange. This will be information that's available to us for the first time. And that report, I think, in its own right will be useful, but will be valuable to the new Health Reform Commission that will be meeting starting this summer on potential changes that can be made under Maryland law to the insurance expansion. We will also be considering two CONs. These are always subject to change at the last minute, but we're aiming to have a certificate of need for consideration at Franklin Square. This is a expansion in surgical services, and at the Columbia Surgical Institute in Howard County. David's team will provide information on a breach assessment at healthcare institutions, comparing national and local data, and I expect we'll have several other updates as it relates to work that we're doing with our work group on surgical services. We won't be bringing regulations back, but it may be desirable for us to update on what some of the feedback has been from that work group, given comments from the commissioners in April as well as today.
Okay. Any questions at all for the director? Okay, well, it's the end of the meeting, and so I'm told by very good authority that I'm supposed to ask for a motion to adjourn. I'm assuming that you're enthusiastic about this. Commissioner Thomas? All right, Mr. Flagg. Thank you very much. Ladies and gentlemen, the meeting is adjourned.